Check. Is it audible?
Madras Medical College, HCL 12. 12.5.
Hello. Good afternoon and warm greetings to everyone. I'm Dr. Avinash, consultant anesthetist at CURI Hospital. Respected dignitaries, esteemed faculties, and dear colleagues, it gives me immense pleasure to welcome you all to Curiosity, the third series on perioperative medicine, featuring today's CME on From Dialysis to Graft Function, Perioperative Considerations in Kidney Transplantation, here at CURI Hospital, OMR, Chennai. CURI Hospital has established itself as a leading center for high-quality, patient-centered care along the OMR corridor. With its advanced infrastructure, state-of-the-art technology, including robotic surgical systems, and a dedicated multidisciplinary team, CURI continues to deliver excellence in healthcare. Over the years, CURI has grown into a trusted institution providing advanced care in urology, uro-oncology, surgical gastroenterology, robotic surgery, and nephrology, with a strong commitment to quality, safety, and compassion. This progress and vision are guided by our chairman, Dr. P.B. Sivaraman sir, and director, Dr. Anandakrishnan Sivaraman sir, whose leadership and commitment to innovation, academic excellence, and patient care continue to shape CURI into a distinguished healthcare institution. Today's CME focuses on a topic of great relevance in modern perioperative practice. Kidney transplantation represents one of the most remarkable achievements in modern medicine, offering patients with end-stage renal disease a new lease on life. However, the success of transplantation do not solely rely on surgical expertise. It requires meticulous perioperative planning, multidisciplinary coordination, and vigilant anesthetic management to ensure optimal graft perfusion and immediate graft function. Through this academic session, we hope to highlight the critical role of perioperative team, that is the team of nephrologists, anesthetists, and surgeons in optimizing outcomes for renal transplant recipients. We are deeply honored to have a Professor Dr. Nagasamy sir, one of the senior most anesthetists in India, and an inspiring teacher to many of us, who will be moderating this academic session. Thank you, sir. We will be beginning this with preoperative optimization and preparation of recipient, followed by intraoperative anesthetic and surgical strategies, and finally postoperative management aimed at achieving immediate graft function. We are grateful to our management for this opportunity, and we thank our distinguished speakers and participants for being part of this academic program. And we are confident that today's discussion will be insightful, interactive, and academically enriching for all of us. Once again, I welcome you all. Thank you.
Good afternoon. In the simplest of languages, a person has been suffering from CKD, a kidney disease, for long. And by this surgery, we are trying to replace his kidney with a kidney from most likely a living donor. So this surgery is not an easy surgery. If anything, the single most important outcome of importance to all the stakeholders would be the survival of the graft. And this survival has inputs from various quarters, right from how the patient is chosen, how the dialysis has been happening, and optimization of his preoperative morbidities, how anesthesia is conducted in the intraoperative period, and how the patient is managed in the postoperative period. So it's a concerted effort from a lot of departments, lot of healthcare personnel to achieve good outcomes. This particular CME has been curated for us to understand in a way how each of our implementations, each of our management processes as the patient travels through the journey of renal transplantation is going to have an enhancing positive effect on his life after transplantation. With that intro, I would like to inform that we have Professor Nagasamy sir in our presence. He is the former HOD of Department of Anesthesiology from Stanley Medical College. He has a lot of accolades. We all know that he's been training thousands and thousands of young anesthesiologists across the state. And most important of all the things that can be attributed to his presence would be, he's been part of more than 1,000 renal transplantations. So his presence is going to be most valuable, and his inputs is going to be very crucial for us to understand how the journey is evolving. With that, our first speaker is Dr. Sivaraman. He is a consultant in the Department of Anesthesiology, CURI Hospital. He is going to give us ideas or inputs about how the renal disease has systemic manifestations and how each of these manifestations have to be optimized before one can decide that the patient is suitable for anesthesia and renal transplantation. Over to Dr. Sivaraman.
Thank you, sir. Thanks for your intro. So it's been a pleasure to meet you all in yet another session of Curiosity series on perioperative considerations in renal transplantation. So my job is to just get clear on the subject of preoperative anesthetic considerations before renal transplantation. I will just give you a gist about the preoperative workup on recipients of renal transplantation. So before going into the topic proper, I would like to brief about a few things on the physiology of kidney so that I would substantiate the reason behind each and every investigations that are being ordered by the anesthesiologist. So renal physiology is being remembered with a mnemonic, a wet bed, where A stands for acid-base balance. Kidney plays a vital role in excretion of hydrogen ion and reabsorption of bicarbonate. W stands for just a minute. Yes. W stands for water removal, which is being done by the countercurrent mechanism. And E stands for erythropoietin production, which helps in production of RBCs. And T stands for toxin removal, that is excretion of majority of the toxins from the body. B stands for blood pressure control, which is being done by the renin-angiotensin mechanism. And E stands for electrolyte balance, especially potassium, sodium, calcium, and uric acid, so on. And D stands for activation of vitamin D, in which kidney plays a vital role in formation of 1,25 dihydroxycholecalciferol, which is the active form of vitamin D. So with this basic knowledge of physiology, now we will go on to the pathophysiology of CKD, because of which we could evaluate the patient according to the pathophysiology. So the first one being the fluid and electrolyte derangement. The major problem is decrease in the neuronal nephron function, which leads to sodium retention, because of which there might be a hypertension to the patient. And there might also be a decreased excretion of the phosphates, which results in hyperphosphatemia. Hyperkalemia may be a multifactorial reason for CKD. The main factor being decreased glomerular excretion. Apart from that, ACE inhibitors or potassium sparing diuretics that is being used for treating the hypertension can also lead to hyperkalemia. In addition to it, hemolysis and acidosis can also increase the potassium level in the body. With respect to acidosis, it is mainly due to the retention of phosphate and sulfate, which exactly results in high anion gap metabolic acidosis. And at last, vitamin D deficiency, which in turn leads to hypocalcemia. Moving on to the next part, that is metabolic and musculoskeletal. The pathophysiology goes like this. Because of the vitamin D deficiency, there is a decreased absorption of calcium from the intestine, which results in hypocalcemia, because of which there is a secondary mechanism which is being activated, which results in increased parathyroid hormone release and resulting in secondary hyperparathyroidism. This secondary hyperparathyroidism leads to increased calcium resorption from the bones, which results in renal osteodystrophy. In addition to it, because of excessive calcium deposition into the vessels can lead to calcification of vessels and results in peripheral arterial disease as well as myocardial ischemia. To add on fuel to this problem, because of decreased phosphate clearance, hyperphosphatemia can also lead to hypocalcemia. With respect to cardiovascular system, CKD patients will have increased renin activity And because of sodium and water retention, there will be hyperkalemia and increased sympathetic activity. All these three things contribute to hypertension in CKD. With respect to the lipid profile, there is an increased triglyceride level, which results in hyperlipidemia, which in turn can also cause hypertension. They both together aggravate this atherosclerosis. And as we all know, because of decreased erythropoietin production in CKD, there is an anemia. All these four factors contribute together to form ischemic heart disease, which is second most common cause of mortality in CKD. CKD patients who are on long-term dialysis on AV fistulas, who result in severe fluid overload with anemia and impaired left ventricular function, can result in pulmonary hypertension. Apart from that, because of increased urea level in the body, can result in uremic pericarditis too. So with respect to hematological changes, anemia in CKD is very obvious because of these 5 reasons. One being decreased erythropoietin, the other being deficiency of iron, folic acid, and vitamin B deficiencies. And because of uric acid level, increase in the uric acid level, it can directly cause bone marrow suppression. And because of increased uremic acid level, there is an gastritis that might result in a recurrent blood loss. Apart from that, uric acid crystals into the circulation can cause increased lysis of RBCs, which decreases the RBC lifespan significantly. All this contributes to anemia. But how does the kidney tackles on its own? It has the following compensatory mechanisms. By increasing the 2,3 DPG, it makes the right shift of the oxyhemoglobin dissociation curve. It also increases the cardiac output significantly and decreases the viscosity so that the microcirculation is being maintained. Iron deficiency anemia in CKD itself is a big topic. Iron usually exists in the body by 2 mechanisms. One is in the transferrin form, which is nothing but a major availability of iron in circulation. So in order to find out the circulation part of the iron, we do transferrin saturation level. The other being the storage form, which is being reflected by the ferritin level. In case of CKD, there are 2 entities which results in iron deficiency anemia. One, it might be due to low transferrin saturation as well as low ferritin, which results in systemic iron deficiency. The other being low transferrin saturation in spite of high ferritin, which results in high restricted erythropoiesis. That is why in order to treat CKD patients, anemia in CKD patients, rather than focusing on a single value of ferritin, going for both transferrin saturation as well as ferritin level, that gives us the clue and exact idea of what is happening behind. So to explain it further, if we could see the first A part, normally what happens is when the RBC's lifespan is being fulfilled, all the RBCs are being sequestrated into the macrophages and it undergoes lysis. Because of this excessive lysis, iron from the hemoglobin is being released into the macrophages and is being stored in the macrophages. In a patient with a normal hepcidin, which is being secreted by the liver, there is an increased opening of ferroportin channel through which the stored iron enters into the circulation and gets bind into the transferrin and enters into the circulation, once again into the bone marrow for hemoglobin production. This is the normal pathophysiology. This is the normal physiology. But what happens in iron deficiency anemia is that because of low ferritin, low iron level in the body, the RBCs, when get lysed, releases less amount of iron into the macrophages. In spite of adequate opening of this ferroportin channel, there is only less amount of iron into the circulation, which results in low transferrin saturation as well as the low ferritin level. Whereas in other conditions, say like inflammatory disease, what exactly happens is the iron in the hemoglobin is said to be normal. When it is getting engulfed into the macrophages and there is an enormous lysis of RBC, there is more amount of iron into the macrophages. But because of inflammatory markers, hepcidin is being increased, which has an inhibitory action on the ferroportin channel, and it later on leads to decreased iron content into the circulation, and therefore there is a low transferrin saturation level. Moving on to the coagulation part, normally CKD patients will have a normal prothrombin, APTT, thrombin time, and platelet count. Because of this uremia symptoms, there occurs an increase in BT level as well as decreased production or poor release of von Willebrand factor and factor VIII. So increase in bleeding time results in abnormal platelet function, whereas decrease in the production of von Willebrand factor results in abnormal platelet aggregation. They both result in uremic coagulopathy. With respect to respiratory system, because of the volume overload, there is an excessive congestion of the pulmonary vessels, which results in hypoxia and hypocapnia. This in turn lead to pulmonary hypertension. In case of patients who are on CABD, that is peritoneal dialysis, intraperitoneal fluid can lead to diaphragmatic splinting, which in turn can lead to basal atelectasis and shunting. With respect to gastrointestinal system, high urea can cause uremic enteropathy, which is being a cause of decreased motility and increased acidity in the patient, which is characterized by anorexia, nausea, and vomiting and diarrhea. And it also results in heavy GI bleeding, which results in anemia. With respect to central nervous system, uremic encephalopathy results and characterized by drowsiness, reduced mental capacities, and even seizure. Disequilibrium syndrome is usually seen in patients who are on dialysis, and it is mainly due to sudden change of extravascular volume and electrolyte concentration causing cerebral edema. CKD patients, the most common cause of CKD being the diabetic nephropathy. These CKD patients will have a typical type of neuropathy, which is characterized by distal symmetric mixed motor sensory polyneuropathy. These patients may also have dementia, especially patients who are on chronic dialysis, which results from aluminum toxicity. Moving on to the targeted evaluation, I'm just going to discuss about only the CKD evaluation guidelines that has been recently updated by KDIGO on 2024, which states that we have to start assessing the patient for renal transplantation even before the patient ends up in dialysis, that is stage 5. So start your evaluation when the patient is on stage 4 and is in progressive state, and the evaluation should be started at least 6 to 12 months before anticipated dialysis initiation. The most important part is counseling the patient and making the patient adhere to the treatment and post-transplantation follow-up. If the patient is said to be a non-adherent patient, even despite of proper counseling, these patients are said to be a relative contraindication for renal transplantation. We also have to assess the patient regarding the psychosocial assessment, which should mainly focus on behavioral, social, as well as the financial issues that might influence the compliance and outcomes after transplantation. Once again, a patient with severe psychological disorder or substance abuse is a relative contraindication for renal transplantation. If the patient is said to be a known smoker and if the calculated PAC here is said to be more than or equal to 30, then this patient should be screened for CA cancer using CT chest. For other patients, we can even do a chest X-ray. Tobacco cessation should be ideally recommended for the patients to whom we start on the renal transplantation workup. Surgical issues, we have to assess on the vascular anatomy, especially in patients who are having a history of peripheral arterial disease, who have undergone previous renal transplant procedures, and those who have been on HD catheters in the lower limb, and those who have undergone pelvic surgery or any history of DVT. In case of malignant polycystic kidney disease, then during the renal transplantation, we should have to go in for a stage procedure, or we can even go in for simultaneous native nephrectomy. With respect to diabetes, if the patient is a known diabetes, then we have to target on the HbA1c. There is no strict guidelines regarding the target HbA1c before the surgery, but routinely they used to follow the target HbA1c as less than 7. In not a known diabetic patient, diabetic screening should be conducted using oral glucose tolerance test. And always remember that diabetes is one of the major risk factors for peripheral arterial disease. In such cases, we have to screen them for peripheral arterial disease too. With respect to infection, active infection is one of the contraindication for transplantation. Any transplant patient going in for transplant evaluation, we have to evaluate for and screen them for these infections like HIV, HCV, CMV, MMR, and human T-cell lymphotrophic viruses. And accordingly, we have to vaccinate them. If it is a live vaccine, it should be given at least 4 weeks prior to the transplantation. patients who are having impaired pulmonary function capacity, which is being assessed using meds, or who are said to be having severe respiratory symptoms, or who are known to have a pulmonary disease, these patients should be recommended for pulmonary function test. And if the pulmonary function test shows irreversible severe obstructive or restrictive pattern, and these patients are contraindicated for kidney transplantation. This is one of the article which shows the effect of pulmonary hypertension on the post-transplant survivors. It has been said that increase in the right ventricular systolic pressure more than 50% is one of the major risk factors for post-transplant mortality and morbidity. In case of malignancy, routine cancer screening is recommended. If there is an active cancer, then it is contraindication for transplantation. If the patient is said to be treated for cancer and has a cancer remission, then a tumor board should be conducted, which should involve oncologists and transplant nephrologists, and accordingly, the transplant should be decided. In case of neurological diseases, if the patient is having a recent stroke, which is less than 6 months, or having a history of TIA, which is less than 3 months, then transplantation should be prolonged. In case of autosomal dominant polycystic kidney disease patients, screen them for intracranial aneurysm. This is one of the recent guidelines from AHA, which is being released in 2012 regarding the cardiac disease evaluation and management among the kidney disease and renal transplant patients, which states that history and physical examination should focus on active cardiac conditions which are being contraindicated for renal transplantation. ECG should be done reasonably for everyone, even when the cardiac disease is not present. Echo should mainly focus on the assessment of left ventricular functions. In case of patients with more than or equal to 3 high-risk factors for myocardial infarction, say like diabetes, prior cardiovascular disease, more than 1 year of dialysis, left ventricular hypertrophy, elderly age group more than 60 years, smoking, hypertension, and dyslipidemia, these patients should undergo non-invasive stress testing like TMT or dopamine stress test. Always remember that even if the patient is said to be having a cardiovascular disease which is being newly diagnosed, if the patient is asymptomatic and if the patient's functional capacity is better, prophylactic coronary revascularization doesn't have any role in decreasing the post-operative mortality in post-transplant patients. So some of the cardiac conditions which are contraindicated for renal transplantation are progressive symptoms of angina, not amenable to angioplasty or CABG, history of recent MI within 3 to 6 months, or a known case of CAD not amenable to any interventions, or severe ischemic cardiomyopathy with a reduced ejection fraction of less than 30%. So how do we manage these patients? If the patient is having a beta blocker, then continue the beta blockers on the day of surgery, as it reduces the rebound hypertension and tachycardia intraoperatively and perioperative period. Strict blood glucose control is not being recommended routinely. The ideal blood sugar CBG should be less than 180. If the patient is having more than or equal to 2 cardiac risk factors, then this patient should be put on beta blockers even before proceeding to the surgery. What would be the ideal time for initiation of beta blockers? The recommendation states that it should be ideally before 24 hours prior to surgery. If the patient is on aspirin, then continue aspirin during the perioperative period, as it decreases the secondary occurrence of CAD. In case of patients with a high risk factors for atherosclerosis as well as CMI, start them on low to moderate dose of statin therapy. This is one of the paper which states that always we tend to overtreat the patients with a lot of investigations. This paper states that risk stratification screening for ischemic heart disease can reduce the unnecessary investigations by around 43%, which helps them financially to be in the upper hand. With respect to GIT, delay the transplantation in patients with active bleeding on peptic ulcer disease. If the patient is having a diverticulitis, acute or chronic pancreatitis, cholelithiasis, which is symptomatic, or if the patient is having an inflammatory bowel disease. Screen all the patients with LFT as we start them on immunosuppressant therapy. And if the patient is said to be having a cirrhosis liver, evaluate them, and we can just plan accordingly so that we can go on both renal transplantation as well as with the kidney transplantation on the same sittings. Also, we have to screen these patients with cirrhosis liver for liver cancer. With respect to peripheral arterial disease, high risk of peripheral arterial disease, then you have to go in for a non-invasive testing like Doppler, arterial or venous Doppler. If the patient is having a severe peripheral arterial disease, then go in for a vascular surgeon opinion and non-contrast CT. If the patient is having a severe bilateral iliac and lower extremity arterial disease or large abdominal aneurysms, which are not amenable to interventions, then these patients are said to be contraindicated for transplantation. This is a paper which gives the importance on evaluation of the peripheral arterial disease, which states that 5 to 10 year incidence of lower limb extremities, peripheral venous arterial occlusion, incidence is very high when the patients undergo transplantation procedure per se. With respect to hematological disorders, focus more on the hypercoagulable states. And if the patient is having any history of GI bleeding, epistaxis, or hemorrhagic pericarditis or subdural hematoma, then these patients said to be having uremic coagulopathy. In such cases, desmopersin can be started as it increases the circulating levels of factor VIII and von Willebrand factor. So with respect to anemia in CKD, anemia in CKD is not a single factor, rather it is a multifactorial. So our evaluation should focus on all these multifactorial diseases, and we have to exclude all these multifactorial contributing factors. KDIGO 2026 recommends preferred IV iron route over the oral supplementations. And these are all some of the IV routes, IV drugs that are being available. The most common being the ferricarboxy maltose at a dose of 750 milligram given in 1 or 2 sittings, 1 week apart. It has an advantage of causing hypophosphatemia to counteract the CKD complication. With respect to ESA initiation, don't go by the absolute value of hemoglobin level, rather individualize based on the patient and patient's comorbidities. These are all some of the formulations that are available for erythropoietin stimulating agents. Moving on to the blood transfusion should be ideally delayed in CKD patients who are being evaluated for transplantation, as it can cause allosensitization, acute hemorrhage, or a rapid perioperative correction of hemoglobin are the 2 indications for PRBC transfusion. So how to just reduce the pre-RBC transfusion perioperatively? Just opt for less invasive procedures during hospitalization of the patient, limit the phlebotomy and number of investigations that is being required, and continue the patients on medical therapy rather than going in for PRBC transfusion. If the patient is said to be a chronic anemic and if the patient is asymptomatic, then delay the transfusion. Moving on to the matching part, I think like nephrologists will speak it in detail about it. I will just give a gist of it. Ideally, we have to go in for 3 types of matching. One is being the blood matching. As we all know, type O is a universal donor and type AB is a universal recipient. With respect to tissue matching, there are 6 entities, 6 HLA matchings that are to be done. If the patient is a donor is a blood relation, then there is said to be a 25% match with the HLA, which itself is enough for proceeding with the renal transplantation. Last being the cross matching, which is said to be the most sensitive for predicting the organ failure and graft rejection. So as a take-home message, focus on the history. The history should mainly focus on the diagnosis as well as the grading of severity of the comorbid conditions. Always mention the native urine output in the history and the frequency of dialysis as well as the dry weight, that is the weight after post-dialysis in the patient. With respect to investigations, just give the investigations pertaining to the comorbid conditions. On the day of surgery, it is a must to do a RFT and serum electrolytes and coagulation profile post-dialysis. Organ compatibility workup should also be done parallelly. The third step being the expert consultation, being a cardiologist or a pulmonary medicine or ENT or a dental or medical gastroenterologist to rule out all the occult infections or say comorbid conditions and stabilize them accordingly. The last being drugs and optimization on the day of surgery. We have to avoid OHAs or insulin, and as well as ACE or ARB inhibitors should be avoided on the day of surgery. But recent publications in IJA states that it is being safe to use ACE or ARB inhibitors on the day of surgery as it doesn't cause perioperative hypotension, and the incidence of AKI is very low. But I just leave it to the consultant's choice. So on the day of surgery, do a dialysis, which decreases the uremic as well as hyperkalemic complications. Thank you. So I just end my talk quoting that renal transplantation is not merely replacing a failing organ. Rather, it restores years to life, dignity, and independence to the patient. So focus more on the comorbid conditions and just reduce the unnecessary investigations or unnecessary prolonging of the surgery as much as possible. Thank you.
Thank you, Dr. Shiva. That was a wonderful session. I request all the audience to type their questions into the chat box. We will take the questions at the end of the speeches. Next is the nephrologist's input into how to evaluate a patient before the start of a transplantation. Most often, the primary caregiver happens to be the nephrologist. He is the point of contact from any quarters. We as perioperative physicians tend to see the patient for a limited window, but it's a nephrologist who's traveling with the patient throughout the time. And there might be situations where the views and opinions of the nephrologist might differ from the views and opinions of an anesthetist. Here we have Dr. Ajay Rathun, a lead consultant nephrologist in CURI Hospital, to give us ideas as to where we can sort out our differences of opinions. Dr. Ajay Rathun, over to you. Thank you.
Good evening, sir. Thank you for a great intro. And Siva, the presentation was really good. And I like the way he ended. So transplantation, dialysis just gives days, but transplantation transfers a life. So So coming to preparing the ground before a graft, so what a nephrologist sees and how we prepare the patient for a transplant. So that is what I'm talking. I'm Dr. Ajay Ratun, consultant nephrologist and transplant physician from CURI Hospital. So for a successful kidney transplant begins weeks or months before the surgery. So the surgery is the day, but the groundwork starts almost 8 to 16 weeks before the procedure or the day. So what has to be done? It has to be a careful recipient evaluation. The patient has to be cherry picked and to see whether they are fit for the transplant. So the careful recipient evaluation has to be done. The optimization of the cardiovascular system and other system has to be done before the transplant. Thank you. So when we think about kidney transplantation, we often imagine the surgical procedure itself. So whenever someone talks to us about transplant, we think about the day of the surgery. So however, the success of a transplant is determined long before the first incision is made. So much of a groundwork is done during the pre-transplant optimization phase, led by us and with the help of other consultants also. So basically, there has to be a careful recipient evaluation. Optimization of the cardiovascular system has to be done before the transplant. There has to be a correction of metabolic abnormalities. So most of the time, patient has a lot of calcium, phosphorus abnormalities, metabolic acidosis would be there, which has to be corrected in total before the transplant. And there has to be a complete assessment of the immunological capability of the patient, and we have to prepare the urological system before the transplant. So these are the things has to be done at least 4 to 8 weeks before the transplant, so that this transplant becomes a success. Yes. So renal transplant is a continuum. So which means, so it is not like a single procedure, as I said last time. So usually the patient comes with CKD to us, which was greatly explained to us by Dr. Siva. So it is a continuous inflammatory state. And once they reach the final stage, they end up in dialysis. And from dialysis, we pick patients for transplant, and the workup is done, surgical and the social screening, and everything is done. And then we optimize the patient for the transplant. So basically, all the patients are sick, and they all have so most of the patient are diabetic, most of the patient would have some cardiac disease, so they need some multiple optimizations so that they can be fit for the transplant, which is a major surgery for them. And then comes the surgery, and then we follow up the patient for the early functional, and the long-term care is also there. So basically, the patient is being followed till the point like the graft works. So renal transplantation is not a single event. It is a continuum that starts during the dialysis, continues through the transplantation surgery, and extends into the lifelong graft monitoring. So what is the different roles as a nephrologist, as an anesthetist, transplant anesthetist, and a urologist? What is the role they have? So basically, as a nephrologist, we work up the patient, and the recipient workup and the immunological workup is done by us, nephrologists. The dialysis, the induction planning, the rejection management, and the monitoring is done by us. And lifelong follow-up and maintenance is done by the nephrologist. Coming to the anesthetist, who plays a very, very critical role in the physiological hour, the important hour of the transplant. They are the one who holds the critical physiological hour. So pre-induction comorbid assessment, hemodynamic and fluid optimization, reperfusion syndrome management, and immediate post-op stabilization is done by the anesthetist. And coming to the urologist, who is the hero of the day, they usually do the vascular anastomosis, the ureteric implantation, and definitive hemostasis and site preparation and physical integration of the donor is done by the surgeon. So, okay. So coming to few terms, so I'll just run through the few slides. And so coming to any transplant can be divided into two types. One is live transplant and the deceased donor transplant. Live transplant is usually through live related and unrelated, like spouse or altruistic. Basic thing is the cold ischemia hour is very, very less and controllable in a live transplant, and it is usually a planned surgery. And deceased donor transplant is through we have a transplant list, and it is through the government list. Coming to timing of transplant. So the transplant can be timed preemptively or on dialysis patients. For example, preemptive means, as Siva has said in one of the slides, like transplant can be done even before the start of dialysis, which means when the GFR is less than 20, that time we can go for a transplant. The major benefit we have while we do a preemptive transplant is the cardiovascular system is intact in that patient, and they would not have gone for dialysis. So somewhat immunologically and systemically, the patient has a very good output. And coming to dialysis, as soon as we start dialysis, we can plan for transplant. So coming to compatibility, so there are two types. One is ABO incompatible and compatible. So which means the RH positivity and negativity is not a thing here. Only the blood group has to be matched. For example, A positive and A negative can be done. So which means, so that is ABO compatible transplant, same group transplant. And next one is ABO incompatible transplant, where we go for different blood group to a different patient. So this is even possible right now because of the increased amount of immunosuppression which is there with us. And one thing to note for an anesthetist is, in ABO incompatible transplant, we tend to do a lot of procedures to reduce the ABO antibodies. So anti-A and anti-B antibodies, for which we tend to do plasmapheresis or give a few procedures to reduce the antibody levels. So on the day of transplant, they are prone to have some coagulation disorders, so which has to be noted by anesthetist. So these are the two scores which we have. One is the kidney donor profile index and the estimated post-transplant survival score. These both are used to tell us with how the graph works or the transplant survival is going to be. Coming to the major contraindication of renal kidney transplant is any active infection is there, the transplant has to be put to hold. Any active malignancy is there, the transplantation has to be put to hold. And severe irreversible extra-renal disease, for example, a severe cardiac failure, a severe lung failure which needs oxygen, we have to put hold for renal transplant. And poor adherence, which means patient is not taking tablets properly and there's going to be poor adherence because of any psychiatric disease or any other neurological disease, we have to not do transplant. And uncontrollable hypotension, because hypotension can lead on to organ underperfusion, which can lead on to graft failure. So when patient does have a hypotension, uncontrollable hypotension, we have to not do renal transplant. Coming to 5 pillars of pre-transplant optimization. So how to optimize the patient? So these are the 5 cores which we usually see. One is the cardiovascular optimization, immunological optimization, malignancy screening, infection screening, and dialysis. So these are the topics I'm going to talk about. So infection, Siva has spoken a lot in infections. Any active infection we must not do, but even HIV patient, hepatitis B patient, and hepatitis C patients also, we do transplant for them with it is not an absolute contraindication. It is a relative contraindication. There are few methods and few steps which we have to follow to do a transplant for HIV or a hepatitis B or a C patients. And only if the infection is under control, we can plan. And let's start with cardiovascular system. So the only point here is the cardiovascular CVD is the leading cause of death after renal transplant. So the renal transplant is going to change the renal state, but whatever cardiovascular problem they have, whatever cardiac failures they have, mostly it is not completely reversible. So cardiovascular disease death is still the leading cause of death in a renal transplanted patient. Diabetic patient, older patients, and patients on dialysis have on a prolonged period, with multiple risk factors of coronary heart disease, they have a high chance of coronary vascular disease. As Siva said, we do ECG, echo, and stress echo for all patients, and angiogram is needed. If recommended, we do angiogram. So this is the protocol which we do in our setup. So all renal patients undergo a cardiac evaluation. So after routine cardiac evaluation, where we do an echo, ECG is done, and if the patient has a low cardiac risk profile, who are low in age and asymptomatic, they are cleared for the surgery, just like. And if they have an advanced, they have an intermediate or a high risk, for example, if they are diabetic, they are symptomatic, and they have an abnormal ECG, first we go for non-invasive stress test, which is a stress echo or a myocardial perfusion scan. If these scans or echo comes positive, then we go for an angiogram. And with an angiogram, we plan for revascularization depending upon the percentage of blocks. For example, if an LAD is blocked more than 70%, revascularization is mandated. So in revascularization, the recommended revascularization by us is CABG, which is a bypass surgery, because post-bypass surgery, we have to wait for 3 months for the transplant. If it is going to be a PTCA or a angioplasty, we have to wait at least 6 to 8 months for the transplant. So the time delay is going to be bigger. So we always tend to prefer bypass surgery for revascularization. Coming to 5 cardiac red flags before transplant. These are the 5 things we must not forget. One is active coronary artery disease, which we discussed. Second is severe LV dysfunction must not be missed. And severe pulmonary hypertension, more than 50, must not be missed, because most of the time our patients have pulmonary hypertension. This can be due to because of log dialysis vintage, can be because of AV fistula high flow, can be because of volume overload, which can be managed. If it is because of volume overload, if it is because of AV fistula, this can be managed before transplant itself. And uncontrollable arrhythmias has to be managed before transplant, and a pacemaker, if needed, the arrhythmia has to be corrected before the transplant. And valvular heart disease. So with severe aortic stenosis or mitral regurgitation, there has to be a corrective surgery if there is severe aortic stenosis or severe mitral regurgitation before the transplant. Coming to cancer or malignancy. So why cancer screening matters? So basically, yes, malignancy, if malignancy is there, we must not do transplant. Why it matters? So basically, ESRD patients have a higher malignancy risk, one. Second thing is, we tend to give them immunosuppressions. This immunosuppressions put them on a higher risk for any cancers. So it, for example, ETG or MMF, they put them on a higher risk for malignancies, and age-appropriate screening is mandatory. So these are the different cancers, and usually even for cancer survivors, we do transplant, but there's always a waiting period. Most of the waiting period is between 2 to 5 years. Only thing where we don't do transplant is myeloma and liver cancer, where good recommendation or the proper recommendation is not still given, but no waiting period is for basal cell carcinoma. Coming to pulmonary disease, so we don't do transplant for patient with supplemental oxygen when patients are on supplemental oxygen, and we have to have an idea about COPD and restrictive lung disease because they could have post-transplant infections, so that has to be there. And smoking cessation is must before the transplant. And severe irreversible pulmonary hypertension is a contraindication to kidney transplant if it is a irreversible pulmonary hypertension. Coming to urological evaluation, so ideally the lower urinary tract should be sterile, continent, and compliant before the transplant, because most of our patients don't see urine till the day of transplant. As soon as they do a transplant, they tend to go for around 6 to 5 liters of urine, which means the bladder, which does have not seen urine for almost a 5 decade, probably it will be pouring out around 5 liters of urine. So the bladder has to be capable and competent to hold that much of urine. So it has to be evaluated before the transplant. So urinalysis and urine culture should be performed in all urinating patients, all urinating patients. And the history of genitourinary abnormality and in individuals less than 20 years should require a full urologic evaluation from cystoscopy to urodynamic study. And with a history of nocturnal enuresis is bedwetting during the night in childhood, which is there after 5 years. It is an important clue in presence of bladder dysfunction with CKD in childhood. And older men, prostate and BPH has to be managed preoperatively. Coming to nephrectomy, so where we do nephrectomies. So usually we all know when a transplant is done, the transplanted kidney is a third kidney. We don't do a nephrectomy for a transplant. So there are only few situations where we do a pre-transplant native nephrectomy. So one of which is infected stone is there, a big stone is there in the kidney, which is causing recurrent infection. When there is heavy proteinuria, when there is intractable hypertension, which cannot be managed with more than 5 or 6 medicines. Polycystic kidney disease, only when the kidney are massive, recurrently infected and bleeding, and there's no space for the new kidney, we do a pre-transplant native nephrectomy. Acquired renal cyst disease, where we have a suspicion of adenocarcinoma and there is an infected reflex, we have to go for a nephrectomy. So these are the reasons where we do a pre-transplant native nephrectomy. So these are the diseases in renal diseases where there's a high chance of recurrence, and we have to think about transplant 1 or 2 times. For example, MPGN type 1 and type 2 and oxalosis are almost like 80 to 100% chance there's a recurrence rate, and better we avoid transplant in these kind of patients. Coming to basic immunology. So why immunology is needed? So basically for a nephrologist, immunology is we need immunology, and we have to understand immunology just because of one word, rejection. So rejection is therefore an end result of recipient's immune response to genetically determined elements present in the transplanted organ. So basic how organ responds to rejection is liver allograft needs the least immunosuppression, and it lasts for at least 2 to 3 decades. So liver is most of the livers are accepted by the patient very well. Lung and small bowel allograft requires the most immunosuppression and they last the least. Heart and kidney are between, and most of the time the rejection are because of T cell dependent, except for hyperacute rejection. Hyperacute rejection are because of preformed antibodies, and most of the rejection, like acute rejection, is because of T cell dependent and rejections. Coming to the type and timings of rejection, one is called hyperacute rejection, which occurs immediate. It is because of preformed antibodies. Mostly it can occur in blood type incompatibility. For example, A to B or B to A, it occurs. And there is going to be thrombosis and occlusion. It is because of preformed antibodies, and it is a type 2 hypersensitivity reaction. This usually we saw at least 2 or 3 decades before. We don't see it now because we properly do a a proper workup, and ABO compatible or incompatible also, we do a proper workup. And we have something called induction, which we'll discuss in the further slides, which is majorly have introduced to reduces hyperacute attacks. Acute rejection occurs weeks to months post-transplant. It is because of T cell rejection, T cell mediated rejection, and that there is leukocyte infiltration of the graft vessels. It is a type 4 hypersensitivity reaction. Chronic occurs months to years post-transplant. It is also again 3 and 4, and it results in intimal thickening and fibrosis of graft vessel. Usually, a person loses graft because of chronic rejection. And graft versus host doesn't occur in blood. It doesn't occur in the kidney. It is usually very common with bone marrow transplants. What happens is the graft has a harmful effect on the host, which is a recipient. Coming to HLA or human leukocyte antigen, I'll just give you a brief idea about what is HLA and what is human leukocyte antigen. So it is a principal allo antigen responsive for triggering the T lymphocytes. So these are the things which this human leukocyte antigen is the one which triggers the T lymphocytes activation, and it presents the antigen to the T lymphocytes. So it is a majorly responsible for the antibody protection. So it is also known as MHC. MHC is major histocompatibility complex molecule. So it is present in the chromosome 6 in the short arm of the chromosome 6. It has two families. One is class 1 and class 2. Class 1 majorly we see A, B, and C, and class 2 it is DR, DQ, and DP, of which DR is very, very important because DR mismatch is the one which could lead on to higher risk of rejection. And they are coming to HLA class 1. HLA class 1 is present on the surface of all nucleated cells and platelets, but it is not present on the RBCs. So HLA1 is not present on the RBCs. It is present on all nucleated cells and platelets. Class 2 is expressed on the B cell. It is expressed. It is restricted to B cells, restricted to and certain myeloid cells, and a subset of activated T cells. So class 2 is only on B cells, myeloid cells, and activated T cells. Class 1 is present on all nucleated and platelets. This is the structure of the HLA structure. So it is present in the chromosome 6 short arm. So what is the function of HLA? So as I said before, it presents a protein antigen to the T lymphocytes in the form of peptide fragments bound to them. So as the T lymphocyte do not recognize the whole unprocessed protein. So as the antigen, it doesn't recognize the antigen as a protein, but this HLA, what it does is it processes the protein into a peptide. So which the T lymphocytes recognizes the peptide and produces produces antibody against it in the body. So this is how the HLA works. It captures the unprocessed protein antigens and processes into the peptides and presents it to the T lymphocytes, and T lymphocytes produces antibodies. So this is how HLA functions. So coming to cross-match. So we know about HLA, and as B, for example, I am a blood group A means I'll have a antibody towards B. Same like which HLA is something is a gene where we have two alleles, and we can have antibodies against other HLAs. For example, if I'm exposed to other HLA antigens, for example, when I have a blood transfusion, I'll be exposed to other antigens in my body, which means I can get antibodies preformed in my body against those antigens. So it is a preformed antibody in my body. So if I have antibody against HLA antigens, and my donor also has the same antigen, I can cause some reaction, and the organ can be rejected. So just like the blood cross match, we do a cross match for the HLA also. So there are multiple methods by which we do a cross match. So first, and this is the only cross match I'll just discuss, and other things I'll run it out. CDC cross match is the one which we do. CDC cross match is a cytotoxic dependent cross match where it is pioneered by Terasiki and colleagues in 1960. What we do here is the recipient, I can take this slide, yeah. The recipient serum. So recipient serum is the patient's serum we take, and if the serum has the antibodies and we take the donor lymphocytes. Lymphocytes, specifically, we take the T lymphocytes and we add the T lymphocytes to the recipient's serum. So donor lymphocytes added to the recipient serum, and we add complement to that also. Why complement added is when the antibodies is there in the serum, and the donor lymphocytes, the antigen is there, they both react. When they both react, the complement is activated and it causes the lymphocyte lysis. So if lysis is there, it is cross-match positive. If lysis is not there, cross-match is negative. If cross-match is negative, we can go ahead for the transplant. If the cross-match is positive, we must not go ahead for the transplant. So percentage of accepted level is 20%. So this is what is called CDC cross-match. Other methods are there. One is called flow cross-match, where we, without the complement, what we do is we do a fluorescence labeled antibody is added, so that here what it does is there's a luminance thing will be there. So with MFI, we know the percentage of activity. Same way, there's another name called PRA, or panel reactive antibody. So here there's a donor and a recipient. But in a cadaver transplant, we usually do not have a donor. We work up the patient, and on the day only we get a donor for us. So here what we do is we take this patient's blood or the recipient's blood and apply it over a multiple panel. And this panel has around 100 to 1,000 of common antigen which is present in the society. So common antigens in the society, and with this common antigen in the society, our serum is added. So if reaction is there, they're going to be PRA will be positive. So it is a percentage or a idea like this patient will have rejection if possible. So with that, we'll tell whether the patient is sensitized or not. So with the percentage of reactivity against the panel antigen. Okay, I don't want to talk about this. Okay, coming on to sensitized patients. As I said before, there's a circulating HLA antibodies that develop from exposure to allogenic HLA antigens. These are the three situations where it can happen. One is pregnancy, where the fetus blood is exposed to the mother, and by which the mother produces antigen against it. Second is blood transfusion, where again the patient will be exposed to HLA antigen, and failed transplant where a failed organ is there. So patients who have circulating HLA antibodies are at a high risk for hyperacute rejection or accelerated acute rejection. So this is the basic about HLA. And next part is we talked about cardiovascular system, malignancy, infection, and immunological workup. The last part of optimization is dialysis. So coming to dialysis timing before renal transplant, practical nephrological protocol. So this is the protocol which we usually follow. So usually what we do is hemodialysis is done within 12 to 24 hours before the surgery. So what we do is we do this to achieve euvolemia, correct hyperkalemia, correct metabolic acidosis, and remove uremic toxins. The blessed transplant always begin with a well-dialyzed patient at the correct dry weight. So this is the target we usually have, which is potassium less than 5, bicarbonate more than 20. Volume status, the patient has to be near dry weight, hemoglobin around 9 to 10, and there must not be any active infection. And this is the usual prescription which we give for the dialysis, which is low or no heparin, low or tight heparin or no heparin usually, and avoid aggressive ultrafiltration, aim a gentle volume optimization, and always check for a post-dialysis potassium. So this is the usual prescription we give. A few words about induction and immunosuppression. As I said before, after the introduction of this induction therapy, the rate of hyperacute rejection has come down significantly. So these are the few drugs which we give. One is besiliximab, or ATG, or anti-thymocyte globulin, or alemtuzumab. So alemtuzumab is not much used in India. The only two drugs which we use is besiliximab and anti-thymocyte globulin. Besiliximab, we use it in a low to moderate immunological risk patients. It is a IL-2 receptor blocker, and there is only minimal hemodynamical effect for the patient. So not much intraoperative challenges will be there when we use besiliximab as a induction agent. Coming to the next agent, which is ATG. ATG can be horse-derived or horse serum derived or rabbit derived. It is a very, very high immunological risk patient. We use this molecule, and it causes severe T cell depletion, and there is cytokine releases possible, and there's high chance of there's a higher rates of hypotension and higher rates of immunological reaction because allergic reaction because of this drug. So on table reaction and on table hypotension is very high with ATG. Alemtuzumab also is a profound lymphocyte depletion is there, but not much of experience we do have with this molecule in India. Coming to immunosuppression, we always go for a standard triple immunosuppression, which is tacrolimus. Tacrolimus comes under the molecule called CNI, and the older molecule which we use was cyclosporin. And the next molecule is MMF or mycophenolate mofetil. The older molecule in this group we used was azathioprine and steroids as a standard. So this is a checklist we always have as a nephrologist. First is hemodynamic and cardiac status. So cardiac evaluation has to be completed, no active ischemia, and acceptable LV function has to be there before the transplant. Dialysis and metabolic status. So dialysis within 12 to 24 hours, potassium less than 5, euvolemia, which is near dry weight at least, metabolic acidosis has to be corrected before the transplant. No, and then we have to screen the patient for infection and malignancy where no active infection, TB screening has to be there, viral serology has to be reviewed, age appropriate cancer screening has to be done. And last is immunological preparedness. ABO compatibility or incompatibility has to be confirmed and kept in our mind. HLA matching should be assessed. Cross match should be negative. PRA and DSA has to be evaluated. DSA is donor specific antibody. And last is the urological readiness where the bladder capacity, adequacy, no outlet obstruction, and urological clearance has to be obtained. Thank you. So we usually, as a nephrologist, we prepare the ground, the anesthetist protects the flow, and the urologist creates a lifeline, and together we turn a donated kidney into a functional organ.
Thank you,
Thank
Dr.
you.
Ajay. That was a lucid elaboration about all the information that has to be taken into account before proceeding with the transplantation. That was really wonderful. I'm sure plenty of the information that was provided by you is like not known to the anesthetist like it has been to me. Thank you very much. Next is the intraoperative period. Intraoperative period happens to be the bottleneck in which a lot of information, lot of events have to be managed appropriately for the graft to have the maximum function in the postoperative period. Many a times, the anesthetist is faced with a grid of information where he's trying to juggle among a lot of activities to ensure the kidney receives optimal flow and adequate oxygenation. He keeps in mind a lot of information, ensuring a smooth flow to the graft, ensuring that all the stakeholders inside the operating room are at peace. To elaborate upon this topic is Dr. Avinash. He heads the Department of Anesthesiology in CURI Hospital. He's profoundly interested in transplant anesthesia. And Dr. Avinash is here to give us inputs about what all events have to be taken into account and how each of them have to be managed appropriately so that the patient derives maximum benefit from the transplanted kidney. Over to you, Dr. Avinash.
Thank you, sir.
Please bear with us for a few seconds. We're getting things sorted out.
Good afternoon, everyone. I'm Dr. Avinash, consultant anesthetiist at CURI Hospital. So today we are going to discuss about the intraoperative strategies for immediate graft function. So the first description of anesthesia for kidney transplantation was between the identical twins on December 23rd, 1954 at Peter Ben Brigham Hospital in Boston. The only monitors that were used was a BP cuff and an ECG, and the recipient received spinal anesthesia. So kidney transplantations are the most commonly performed transplantation in each of the three major regions of the world, like the US, Europe, and Asia. Two types of donors are cadaveric and living donor. The living donors has a higher success rate. So the main goals of management of the living donor kidney is allay anxiety, stable hemodynamics, blend surgical stress, maintain renal blood flow, urine output of more than 2 ml per kg per hour, and maintain the post-op analgesia. We'll be discussing about all this in detail. So anesthesia for the living donor nephrectomy, after the standard ASA monitoring devices like the NABP and 5-lead ECG, saturation probe, ETCR2, temperature, and urine output, GA general anesthesia is administered for almost all these cases. Supplemental with the regional local anesthesia for analgesia is preferred. So invasive monitoring is selected only for complicated donors with symptomatic coronary artery disease and history of congestive heart failure and obesity. An artery line is placed either before or after induction. So for coming to open donor nephrectomy, usually the left kidney is preferred because of the site as well as the longer length of the vessels. A lateral decubitus position is preferred. So the table flexion for surgical access is done. Careful positioning to prevent pressure necrosis, airway compromise, and venous access obstruction. So renal protective pharmacological measures include mannitol. We use around 12.5 to 25 grams IV. It's given 15 minutes prior to renal artery clamping. It improves kidney. It improves kidney protection. Furosemide 20 to 40 mg IV maintains natriuresis, helps in maintaining natriuresis and decrease renal oxygen consumption and inhibits sodium potassium ATPase. Now coming to the laparoscopic and robotic living donor nephrectomy, anesthetic considerations involve ERAS guidelines, minimally invasive surgery, early mobilization, smaller incisions, less pain and opioids, faster recovery, and fewer complications. So the key techniques and the benefits of minimally invasive surgery is shorter hospital stay, reduced inflammation, and quick return to activity. I think the slide is not projected here. Just a minute. No, I'm in the next slide. I'm in about nephrectomy, robotic nephrectomy. Go to the next slide. Okay. Sorry for the inconvenience. So, coming to the robotic and laparoscopic donor nephrectomy, the anesthetic considerations are aimed at ERAS guidelines. That is, ERAS enhanced recovery after surgery for early mobilization, smaller incision, less requirement of opioids, and as it is faster recovery after surgery. So concerns during pneumoperitoneum include creation of pneumoperitoneum, the intra-abdominal pressure of at least 15 to the 20. Physiological effects include GFR, reduced renal blood flow, transient decrease in urine output, and intra-abdominal pressure of greater than 15, and decreased renal perfusion.
Sorry for the inconvenience. We are experiencing a small glitch. We'll be back in 2 minutes.
Sorry for the delay. There was a glitch in the Zoom. So we'll be continuing our used yeah, you on, yeah. Sorry for that. Next slide, next slide. Yep. So the concerns of robotic surgery include creation of pneumoperitoneum, and as I told you, the physiological effects, decrease in GFR, decrease in renal blood flow, and transient decrease in urine output, which and IAP of greater than 15 leads to a decrease in cardiac output as well as decrease in renal perfusion. So the factors affecting the renal function during this are the level of intraabdominal pressure, patient's intravascular volume status, the degree of hypercapnia, and baseline renal function. Fluid strategy for this donor nephrectomy involves usually these patients can be loaded with fluids crystalloids overnight. A colloid bolus can be given before pneumoperitoneum, as in some studies. It is associated with increase in urine output and increase in stroke volume. Hemodynamic targets during pneumoperitoneum is maintaining a MAP of more than 70 and maintaining urine output of more than 100 ml per hour. And the post-operative pain management for a live donor nephrectomy involves it's mainly for open surgeries wherein there's a large incision, and significantly after laparoscopic surgeries. Sources of pain include tissue dissection, port side pain, lower abdominal or retrieval incision, pelvic or organ nociception, and diaphragmatic irritation. Analgesic options include multimodal balance analgesia, has a superior pain control and decreased opioid requirement, safe and effective. Regional techniques include thoracic paravertebral block, tap block, epidural analgesia. Adjuncts are in local infiltration, intravenous paracetamol, and patient control analgesia with fentanyl. And coming to our recipient, preoperative preparations include dialysis on the day of surgery, heparin-free, correct hyperkalemia and acidosis if present, routine fasting of 8 hours for solids. We use proton pump inhibitors, and blood is to be cross-matched and reserved. Anesthesia for renal transplant, the type of anesthesia, GA is preferred over regional. The disadvantages of regional anesthesia include CVP and artery lines have to be placed in an awake patient, difficult in handling major blood loss in a vasodilated patient, hypertension. These patients have coagulopathies and the risk of extradural hematoma, medical legal implications of postoperative peripheral neuropathy, and long procedure for an awake patient. A patient could get restless. Goals of intraoperative anesthetic management include maintaining adequate renal graft perfusion, avoid hypotension, maintain optimal intravascular volume, correct electrolyte abnormalities, prevent acidosis, provide good analgesia, avoid nephrotoxic drugs, and maintain hemodynamic stability during vascular anastomosis. Monitoring are standard monitors like ECG, pulse oximetry, capnography, temperature, NABP, or invasive blood pressure. Advanced monitoring including artery line, CVP, and cardiac output monitoring. T is used in high-risk cardiac patients. And coming to the main, this is one of the main considerations in recipient, protection of the AV fistula. So it's to be examined for infection, patency, and distal pulses. IV line to be secured only in the opposite arm. That it should be carefully padded and periodic patency checks should be done. And these patients are prone for pathological fractures, hence care should be taken during shifting and transferring of the positioning of the patient. Induction of anesthesia, the key considerations include these patients are full stomach, so there's delayed gastric emptying, which is common in ESRD, risk of hyperkalemia, and cardiovascular instability. So drug choices, rapid sequence induction is mostly preferable because of the full stomach status. Because of hypoalbuminemia, has increased free radical fraction, and uremia causes disrupted blood-brain barrier, causes exaggerated CNS drug effects. So dose titration is essential. The most commonly preferred induction agents are propofol and thiopentone, and in high-risk cardiac surgeries, etomidate is chosen. Coming to opioids, fentanyl is commonly used. Remifentanil, we use remifentanil too. Morphine and pethidine are avoided due to the metabolite morphine 6-glucuronidase, and similarly norepinephrine, which is an active metabolite. In muscle relaxants, scoline can be used safely if the potassium is less than 5, and preferred choice is atracurum and cisatracurum. For blunting the intubation response, we use esmolol and fentanyl, and maintenance is with desflurane and isoflurane. Sevoflurane is also safely used, but it has rare nephrotoxic toxic effects like compound A, which is found in only animal studies. So perioperative glycemic control is very vital. Hence, intraoperative CBG monitoring is to be done every 2 hourly for diabetic patients. Poor glycemic control leads to increased infection risk, delayed wound healing, higher morbidity, and graft complications. So the recommended targeted CBG is 140 to 189. Similarly, maintaining normothermia is very vital. So the strategies which we use is use of bear huggers or forced air warming blankets and hotline warmers. Perioperative hypothermia leads to surgical site infection, coagulopathy, pain, and prolonged neuromuscular blocking. The recommended temperature is 36.5 degrees Celsius. And thromboprophylaxis, intermittent pneumatic compression stockings has to be applied for all recipients, both intraoperative as well as in the postoperative phase. Perioperative fluid management, the goals is to maintain adequate intravascular volume, ensure sufficient graft perfusion, prevent hypotension, avoid acute tubular necrosis. The CVP to be maintained is more than 12 to 15. Systolic BP greater than 130, MAP of greater than 80. So the total IV fluids is at least 30 to 50 ml per kg per hour. So initial target stroke volume variation value is less than 15%. Higher infusion rates to be given during ischemic or reperfusion phase. So there are 3 strategies. The traditional one is the liberal phase, liberal strategy wherein up to 30 ml per kg per hour is infused. Target CVP of greater than 15. Next is a restrictive strategy wherein they maintain CVP of 7 to 9. The most commonly used is the biphasic regimen, pre-ischemia phase, CVP of around 5 mmHg, and in ischemic or reperfusion phase, CVP maintain up to 15 mmHg. It helps in improving early graft function. Monitoring the fluid responsiveness in reperfusion phase, after the clamp removal, there's sudden pooling of blood in the graft. This is release of ischemic mediators causing vasodilatation, high risk of hypotension. So static markers like CVP, pulmonary artery pressure, and TE are used, but the most dependable predictor is dynamic markers, the intra-arterial catheter, which helps in detecting the stroke volume variation, as we can see in every breath of the inspiration and expiration. The recommended MAP is 80 to 110 during this phase. So the choice of fluids are crystalloids. The normally used crystalloids are RL, plasmalite, and normal saline. But balanced crystalloids are chosen over normal saline because it has decreasing inotropic requirement in some studies. Colloids are used rarely. Coming to the balanced crystalloid solutions, they are currently recommended over saline for fluid management in kidney transplantation. Evidence suggests that they reduce the incidence of delayed graft function by approximately 10%. So here are a few studies which shows that balanced salt solutions have a better effect on the donor kidney than 0.9% saline. Normal saline causes hyperkalemia compared to oral due to extracellular shift of potassium due to acute changes in pH, which occurs with hypochloremic metabolic acidosis. Here are a few reference articles. And coming to colloids, human albumin improves short-term and long-term outcomes in renal transplant surgery. So 20% albumin, 0.8 to 1.6 mg per kg, helps in improving the graft survival. Artificial colloids such as gelatin, dextran, HES may cause anaphylactic reactions, bleeding complications, and reticuloendothelium dysfunction. And mannitol is used intraoperatively. It's osmotic diuresis. It helps in tubular protection, protects against post-transplant tubular necrosis, vasodilatory prostaglandin release, and free radical scavenging. It increases the renal prostaglandin production. So it is often given at clamp release, that is before graft perfusion, 250 ml of 20% mannitol before reperfusion. Furosemide, it counteracts antidiuretic hormone response, reduces the renal oxygen consumption, promotes diuresis. The benefit of early graft function is unclear. So it is usually administered 10 to 15 minutes before clamp release. And dopamine, the use is controversial. The low dose is commonly used to stimulate dopaminergic receptors in the kidney vasculature to induce vasodilatation. ABG, so it alerts anesthetist for any metabolic and respiratory acidosis, point of care investigation. And preservation of donated kidney. Kidney from living donor must be flushed with preservation solution, iced RL containing heparin, isopropyl, and mannitol. Cold ischemia time to be restricted to 20 minutes. Reperfusion solutions in renal transplantation. It reduces the ischemia reperfusion injury, removes microthrombi and metabolites, improves early graft perfusion. So this one, I think Dr. Ajay already spoke regarding the cold storage, wherein the commonly used are, so solutions are the HTK, which you use intraoperatively. It contains high potassium, impermanence, buffers, and antioxidants. Its high potassium content may cause transient hyperkalemia on reperfusion. So intraoperative reperfusion flush, it is before or clamp release. Cold oral can be used. Balanced crystallized solutions are also used. It helps in reducing the potassium load and improve microcirculation. Other pharmacological adjuncts are mannitol, furosemide, and heparin. Immunosuppressant therapy, as Dr. Ajay had explained, it is started during induction, right before the induction of anesthesia. This is already discussed. So anesthetic considerations for us are interactions with volatile agents which may increase renal vasoconstriction, and muscle relaxants enhance neuromuscular blockade, and with opiates it may cause alter the hepatic metabolism. So calcineurin inhibitors is a nephrotoxicity and neurotoxicity which may cause seizures. Steroids cause hyperglycemia and infection risk, and immunosuppression cause delayed wound healing. So role of steroids in renal transplantation, the purpose is to prevent acute graft rejection, suppress inflammatory response, reduce ischemia, reperfusion injury, and it's a part of standard immunosuppressive regime. Timing is high dose IV is given intraoperatively, usually before or at the time of reperfusion. It's followed by a post-operative tapering regime. Commonly used ones are methylprednisolone and prednisolone. The mechanism of action is inhibits T cell activation, reduces cytokine production, stabilizes lysosomal membranes, and decreases capillary permeability. Benefit is it decreases the incidence of acute rejection, increases early graft injury, and improves early graft function. Side effects are hyperglycemia, hypertension, delayed wound healing, and increased wound infection and gastritis. So the common complications that we should watch out for during clamp release are hypotension, hyperkalemia, ventricular arrhythmia due to reperfusion injury. The kidney may get darker and the nil urine output. It's a sign of hyperacute graft rejection, and which may lead to DIC. So intraoperative urine output, another important one is, it is an important indicator of graft perfusion and function. It helps assess the success of vascular anastomosis and reperfusion. So initially there's an immediate diuresis occurs after reperfusion. The urine output may reach up to 500 initially, caused by osmotic diuresis and tubular dysfunction in early graft period. Target urine output is generally more than 1 to 2 ml per kg per hour. Often it is greater than 100 ml per hour in functioning grafts. The cause of low urine output include hypovolemia, hypotension, vascular thrombosis, acute tubular necrosis, hyperacute graft rejection, and obstruction of urinary catheter. So the measures to improve are to maintain adequate MAP of greater than 80. So adequate fluid administration and mannitol or furosemide can be used before reperfusion. So reversal patient is usually exhibited on the table. So we should assess the reversibility using TOF monitor, and neostigmine with glycopyrrolate is safe for these patients. Post-transplant hypotension. So avoid alpha agonist vasopressors like phenylephrine. The CVP may decline drastically like 25 to 50% in initially 1 to 2 hours after revascularization, despite aggressive fluid management. The causes are redistribution of fluids, the changes in vascular permeability, and increased nitric oxide levels. So the management for this includes increased hydration. Causes the arterial distension and subsequent release of atrial natriuretic peptide, and PRBCs should be used whenever required. Post-operative IV fluid regime is based on the previous R urine output plus 100 ml. Post-operative care, they are usually admitted in high dependency unit. Monitoring the fluid input and output is essential. Re-exploration of the wound should not be delayed if kinking of the vasculature attachments or obstruction of the ureter is suspected in their course. And for pain management, it's usually mild to moderate. TAP block can be given. Other blocks are fascia transversalis block, QL block, thoracic paravertebral block, multiple analgesia with paracetamol, tremarol, dexa, patient control analgesia with opioids. NSAIDs are avoided. And coming to blood transfusion, its indication significant intraoperative blood loss, severe anemia compromising oxygen delivery, and hemodynamic instability. So transfusion threshold is generally HB less than 7 to 8 in stable patients, and high threshold in cardiac and hemodynamic instability. So there's a reference article which shows us the concerns on renal transplant are risk of alloimmunization, formation of anti-HLA antibodies, may increase the risk of graft rejection, possible transfusion reactions, and perioperative transfusion. It is associated with increased acute rejection, and patient without transfusion showed better graft function. Other alternative strategies include preoperative hemoglobin erythropoietin therapy, and minimizing surgical blood loss and careful intraoperative fluid management. And for transfusion, we should use leukocyte depleted blood products, ensure cross matching and compatibility. Thank you.
Thank you, Dr. Avinash. That was an elaborate presentation. You spoke about the renal implications of all our medications, how to go about the use of fluids, the pros and cons of crystalloids, balanced salt solutions, and normal saline, use of, indication of intraoperative blood transfusion, use of various monitors for the safe conduct of anesthesiology in the intraoperative period, and preparation for reperfusion and eventual extubation and transfer to the PACU. With that, we are going to the surgical angle. For the outcomes to be optimal, we can categorize the factors into 4 or 5 categories: patient factors, donor factors, anesthesiology factors, physician factors, and one thing that doesn't commonly come into the minds of the physicians would be the surgical angle. We all know that the length of the renal artery or the length of the renal vein has to be optimal for a safe anastomosis to be procured on the recipient side. We do not know anything more than this. To throw some light on this subject, I invite Dr. Manas Ranjan Panda, a senior urologist, profoundly experienced in transplantation in kidneys, for the next talk. He would give us inputs as to how surgical techniques help to enhance the function of the graft in the postoperative period. Over to Dr. Manas.
Good afternoon, everyone. Photo. Okay. So as we are getting the technical things sorted out, I would like to thank the previous speakers who have highlighted the importance of the previous pre-op evaluation and the anesthetic considerations which are to be considered before and during the transplant process. And Guhan is there who will, Dr. Guhan, he will be speaking about the post-op management of the patients. Now, the patient spends hardly the minimum amount of time in the operation theater. Okay, so let's begin the surgical part. The patient of CKD, once before he enters the operation theater, he is a CKD patient who is on regular dialysis. And after he leaves the theater, he is a patient who doesn't need any dialysis. He has his own urine output, has his own functioning kidney. So in this brief talk, I'll be trying to cover the aspects of the surgeon on the donor side as well as on the recipient side. What are we looking at? Today, we'll be learning about the 3 points which are important in any surgery: anatomical mastery, the technical precision, and critical thinking. So in the anatomical part, what are we looking at? We are looking at the recipient iliac vessels, the dissection in the donor, and the bench dissection also. The technical precision involves the anastomosis part, where the artery, vein, and the ureter are anastomosed to the respective areas of the recipient patient. Now, critical thinking, because every surgery will have or may have some or the other complications. So we should be prepared for that, and an open mind should be kept in managing those cases. Now, these 3 are the most important points which, as a surgeon, I would be looking at during a transplant. The graft viability, and it is time dependent. Minimizing the warm ischemia time is the most important. More important than the cold ischemia time is the warm ischemia time. And every stitch counts for long-term graft survival. Before we go into the bench surgery, I would like to highlight a few features which we look at as a donor surgeon. Now, donor surgery may be open or laparoscopic or robotic. With the advanced techniques coming up, we have slowly upgraded from open surgeries to laparoscopic and robotic modalities. The difference comes in the initial few minutes after the donor artery and the vein is clamped. So in an open case, you would be taking the kidney directly from the hands of the donor surgeon directly onto the bench. And in case of laparoscopic or in a robotic case, the incision is already prepared, although there can be a 30 seconds to 1 minute additional time in retrieving the kidney from the donor, from inside the donor and placing it on the bench. Now, what is the bench? The bench surgery, basically, it is considered as one of the most important parts of preparing the kidney before it goes to the recipient body. So as soon as the kidney is brought out from the donor's body, the back table preparation involves flushing of the kidney. Flushing of the kidney is done with various solutions, as Avinash has mentioned. Most commonly, we use the HTK solution. Depending on the number of arteries, all the arteries should be simultaneously flushed, and the perfusion should be visibly seen in the color change of the kidney on the bench. The initial kidney which is coming out from the donor is red and it is vascular. As soon as we start perfusing the solution, slowly the color change of the kidney shows a white kidney, and we should make sure that there is no red areas or patchy areas. Then we should be looking at various accessory arteries. Did we miss any artery? Did we perfuse all the arteries? Eventually, the effluent coming out of the vein should be clear. That is one of the most important points. And smaller branches can be ligated on table, or you might have, it is easy to miss on the table because of the color of the fluid which we are giving. It will be transparent. Another important aspect is the ureter. The ureteric blood supply is a very important and critical step. And depending on the variation of the artery, small branches from the kidney itself might be supplying the upper part of the ureter, which we may not realize. And there is a triangle between the ureter and the kidney surface, which is the golden triangle, and should not be disturbed in any case. Going to the recipient, the first thing that we think about is the incision. Now, what should be the incision? The recipient patient is in supine position, and we make an incision 1 inch away from the ASIS and running 1 inch up to the above the inguinal ligament. This gives us good access to the arteries and the vein which we are going to anastomose it to. So the right side is the preferable side because the vein and the artery are slightly more approachable and slightly higher and accessible. That is a shallower, placed shallower on the right side. Preservation of the ilioinguinal nerve as it runs close to the incision, and a medial reflection of the peritoneum is important. In these cases, the peritoneum is not opened because it prevents the contamination from the peritoneum or into the peritoneum also. And the recovery post-operatively is also better because we are not touching the peritoneum, so the bowel recovery is improved. Other ways, just like the donor, there are other ways of doing, approaches of doing the transplant is recipient transplant is by laparoscopic or robotic methods. They have been shown to be equivalent. The results have been shown to be equivalent, although in that we go intraperitoneally, we drop the bladder, we expose the vessels, and then anastomose. Going to the vascular dissection. This begins before the donor is taken inside. First, the recipient is taken inside, and after the incision, the Gibson's incision is made, we approach the retroperitoneum, and the dissection is continued to dissect the iliac vein first. It has to be mobilized enough and to allow a tension-free anastomosis. Vein is a very critical element, and that decides the position of the kidney after all the anastomosis is done. And small lumbar arteries, small lumbar branches from the vein have to be taken care of as we go proximal in the dissection of the external iliac vein. Now the iliac artery. Iliac artery, the preferable is internal iliac because we can do an end-to-end anastomosis and the chances of stenosis are less and the flow is linear. Although in some cases, the external iliac artery may be chosen as the one which is anastomosed to. In all cases, we should check for calcifications before clamping because a small calcification in the area of the incision might migrate and lead to the anastomosis failure later, or complications like suppose the external iliac is clamped and we missed calcification which was there. Then it might run into the lower leg limb vessels and it can cause thrombosis there. So a careful observation for calcification pre-clamping is very important. Also, when we are making a cut on the artery, we make sure that it is a clean cut with a knife, because intimal dissection is also very common in these cases. Now, lymphatics. As we dissect the vein and the artery, the surrounding, it is all covered with the lymphatics. So careful dissection is done to ligate all the possible lymphatics to prevent the excessive drain output post-operatively. And in a long term, the lymphocyte formation. This is the most important slide. This is the factor which determines the function of the kidney immediate post-operatively as well as in the long term. Any variation has long-term effects also, as any small variations in the acute stage may lead to earlier chronic rejection of the kidneys. 45 minutes is the timeline which is considered safe from the time the kidney is, this is for live donor transplants, from the time the kidney is taken away from the donor after clamping the donor renal vessels until we reperfuse after the anastomosis is complete. The arterial and the venous anastomosis is complete. So there are two warm ischemia times. First warm ischemia time is from the donor to the bench. That is 2 to 5 minutes is considered okay. Then comes the cold ischemia time. Cold ischemia time is until the perfusion is started, from the time the perfusion is started on the bench until it is anastomosed to the corresponding recipient vessels and the clamps are released. So the total time is considered less than 45 minutes is considered okay. Then this 12 to 24 hours. So this factor is for disease donor transplants. So in disease donor, we can consider a margin of 12 to 24 hours. Unlike other organs, kidney has good viability even if the cold ischemia time is slightly higher, although not the ideal situation. But in cases where the donor kidney is coming from another hospital, or it is delayed evaluation of the recipient, because disease donor transplants depend on cross matching, and this much timeline is considered relatively safe for a disease donor transplant. So this line is very important. The time is graphed and every minute saved is a unit of GFR earned. Coming to the venous anastomosis, the venous anastomosis is done most commonly as an end to side method to the external iliac vein. So using a 5060 running sutures, the anastomosis is done and it is kept in a way so that it does not stenose easily. And the graft orientation, as I said before, depends entirely on the renal vein and the renal vein and the external vein anastomosis. Then comes, so after finishing the venous anastomosis, we go to the arterial anastomosis. The artery most commonly anastomosed to is the internal iliac artery because it is end to end and the flow is better. The end to side external iliac is also considered a gold standard, but it is secondary. A Carroll patch can be considered because in a live donor, we cannot take a Carroll patch as it will be resecting a part of the aorta. But in case of diseased donors, a Carroll patch can be considered, which simplifies the procedure. The technique used is parachute technique. The donor artery is parachuted into the recipient artery. It avoids the kinking or tenting of the artery. And then once the anastomosis is done, we orient both the vessels and the kidney accordingly. Now, managing multiplicity. So, vessel reconstruction is one of the factors which is which gets affected with multiplicity of the arteries or the veins, and there are various ways in which these can be managed. Suppose there are two arteries and you encounter two arteries intraoperatively. There is one extra artery going from the lower pole. Then what do? We anastomose it to the surrounding vessels which might be there, like the external iliac or inferior epigastric, or one to the internal iliac, one to the external iliac. Accordingly, also goes true for the venous anastomosis. Now comes the moment of truth. After both the anastomosis are completed, we release the clamps. First, the arterial clamp is released. At that moment, you see the kidney getting flushed red, and then you release the venous clamp to allow the venous outflow to go. Soon as the clamps are released, the first question comes from the nephrologist. How is the kidney? So the first question, the answer which they expect is the kidney is red and turgid. That is what is an ideal reperfusion. Slowly, as we observe, within a minute or two, the urine also might start trickling, and everyone's heart rate is then comes down. And then we go for the third anastomosis, which is the ureteroneocystostomy. Now, there are various ways of anastomosing the ureter to the kidney, to the bladder. One of the ways is non-refluxing anastomosis, and which is more commonly done, and another way is a refluxing anastomosis. So this is the technique which is very commonly used, least required technique. In this, a small tunnel is created, just like the native ureter. They pass through a tunnel intravesically and then open up. So similar replication is attempted by creating a short, direct, non-refluxing tunnel. Mucosa to mucosa anastomosis is done using 40 or 50 Vicryl because they are dissolvable and are less prone to leading to stone formation postoperatively. And a detrusor tunnel is then created after creating a mucosal flap over the ureter. To stent or not to stent. In case you are doing a refluxing anastomosis, most of those cases are not stented. In case we are doing a non-refluxing anastomosis, most of the cases are stented. A double J stent reduces the risk of early obstruction or leaks. So in high-risk anastomosis, it is considered mandatory. Now, what happens when do we remove the stent? We can remove the stent 4 to 6 weeks. That is the ideal time to allow for the mucosa to heal and prevent any leaks and to prevent any strictures also. Now, one of the patients which we had seen post-renal transplant had a forgotten stent. That patient came to us 20 or 15 years later with the entire kidney, the ureter, and the bladder full of stones. That is one of the risks of encrustation or stone formation is what that is why the necessity to not forget and remove the stent in time. Before the closure, final hemostasis is confirmed. The hilar nodes for lymphatic leakage is checked. The renal artery position is checked. Whether the flow, the turgidity of the kidney, and the position of the vein and the artery is checked. JP drain is placed posterior to the kidney for observation for catching any immediate post-op complications like a leak, and a layered closure of the fascia is done. Now let us go to 2-3 case scenarios. The first case scenario that I'm going to present here is of a lower pole renal artery. Now during reperfusion, a small lower pole artery may be found. What is the significance of that artery? Can we just leave that artery, a lower pole artery, considering it is small volume? No, we cannot leave the artery. Every single attempt should be made for reconstruction of that artery. You can anastomose it as a separate anastomosis with the external iliac, or you can anastomose it along to the main renal artery, and the main renal artery can then be anastomosed to the external iliac. Sudden darkening of the kidney. After releasing of the clamp, what do you do? What are the conditions which come into your mind if there is a sudden darkening? The first thing that we should consider is whether the artery and the vein is okay, whether the inflow is going well, or whether the outflow is coming okay. So we should check for the arterial thrill, we should check for the venous outflow, and once we consider that, then the next situation may be a case of hyperacute rejection. All these, suppose it is a surgical error, then we need to, in some cases, have to take out the kidney, flush it again, or we have to adjust the position of the kidney according to the position where the arterial inflow and the venous outflow is nice. So some take homes from this presentation is bench surgery is the most important part where the artery and the vein is dissected, and we assess for any accessory arteries which might be there, and for any tear of the capsule should be repaired before the patient is taken, before the kidney is taken to the recipient body. The warm ischemia time is the very important. The target warm ischemia time should be combined warm ischemia and cold ischemia time should be less than 45 minutes for optimal graft function. The venous outflow is the most common cause of early graft loss, and we have to be vigilant about it and prevent technical errors. The ureteric health is very important, and the ureter should not be dissected excessively to prevent the delayed complications like stricture or leak. So last but not the least, it is a team effort, a donor team, a recipient team, and the nephrology team, and nonetheless, the anesthetist team is a part of a complete renal transplant team, and it is a teamwork which makes the success of a transplant possible. Thank you. Any questions can be asked.
Thank you, Dr. Manas. Manas, we have reserved the questions for the last. After
Okay,
end of all
sure.
talks.
Thank you.
Thank you, Dr. Manas. Everybody loves a pink target kidney. It is the most beautiful sight that one can have inside an operating theater for renal transplantation. Next is Dr. Guhan. Once the patient gets extubated and shifted to the post-operative ward, it entirely comes under the domain of the nephrologist. This particular period can be a minefield. There are plenty of factors that have to be taken into account. The nephrologist has to monitor the urine output. He has to titrate the immunosuppression. He has to safeguard against infection. He has to ensure that the vessels are flowing up properly. So it's not an easy task. Dr. Guhan, a dynamic young nephrology consultant from CURI Hospital, is here to give us information about how he treads this path using subjective and objective evidences. Over to you, Dr. Guhan.
The third category is the delayed graft function, wherein it is defined by the need for hemodialysis in the immediate post-transplant period. So requirement of dialysis in the first week post-transplant is what is defined as delayed graft function. So let's talk about four transplant stories, and how each of these are being based on different outcomes. So we have 4 patients, each with a creatinine of 3 milligram per deciliter. Let's go to our patient number 1. So he's a 38-year-old gentleman who underwent a live-related renal transplant with his mother as the donor. Post-operative day 1, creatinine was 6. So this classifies as an immediate graft function because pre-transplant 6.6, 50% at BOD1. So this is immediate graft function. So he would have just the routine complications of what we would see in the post-transplant period, which is issues of polyuria and pain. So let us take up the first challenge of a polyuria. So what is very interesting to note is, in the post-operative period, the urine output reaches anywhere between 500 ml to 1 liter per hour. And the interesting pathophysiology of how this differs from the pre-transplant period or the native kidney is that our kidney that we have transplanted is a denervated kidney. There are no neural connections, but then the humoral or the hormonal responses are still intact. So the sudden response to a sympathetic surge is less regulated for a post-transplant kidney, which is why we keep filling up the patient with a good amount of preload to ensure adequate perfusion. So this concept of a denervation is very important, which is why we keep chasing the output in the post-transplant period. Various transplant centers have different protocols wherein they either, in the initial period, they add on to the hourly output. For example, if the previous hour's output is 600 ml, the tendency is to add on 100 ml and give 700 ml to the next hour, to the maximum capped of 1 liter. And as the patient goes into his POD2 and POD3, we try to reduce it to match the previous hour's output. Regarding diuretics, although initially there were some benefits for diuretic use, we've come to realize that diuretics, there is no routine use that is recommended. Diuretics should more often be used to reassess the volume status. If at all you feel the patient is edematous, to bring out the extra volume, a diuretic is useful, but routine use of diuretics is not recommended. And regarding fluid of choice, there's always been a fluid wars when it comes to even a normal surgical procedure. In the transplant, there are more than enough confusions, so there is no guideline recommended fluid of choice. However, I'll walk you through a few of the options that we have. So our first one is our normal saline. So this is for just to recapitulate our basics, 0.9% saline, which consists of 154 milliequivalents of sodium and 154 milliequivalents of chloride. How it differs from ringer lactate is that it has no buffer. How this developed to be called as the normal saline is because it was used commonly in the cholera pandemic. When there was a lot of sodium and chloride loss, many of these patients had a lot of diarrhea. This was used as the replacement fluid of choice, and which is why it started being called as the normal saline or the normal fluid. But what happened is, the important thing to note is that it has 154 milliequivalents of chloride, and anytime there is high chloride, there is a risk of hyperchloremic metabolic acidosis. And this, by causing transcellular shift, can worsen hyperkalemia, and by activating the vessel wall can cause worsening hypertension. So what is important to note is that normal saline is actually not normal. So the other options that we left with are the balanced solutions, which vary between ringer lactate and plasmalite with a pH of between 6.5 to 7.4. How it differs from normal saline is that it has a buffer, which in the form of lactate or acetate. Why we are initially worried about these plasmalite or ringer lactate is because of theoretical risk of hyperkalemia. But this is more commonly seen only in patients with a low urine output, those who have rapid infusions, or those who have a pre-existing hyperkalemia. This is not seen in a normal individual with a good urine output and who does not have pre-existing hyperkalemia. So based on this, what are the current recommendations? Before that, just a snapshot of the contents of the three fluids. So the RL has the buffer of lactate, the plasmalite has the buffer of acetate and gluconate. And if you note, the ringer lactate is more isotonic and more similar to our human plasma than our sodium chloride. So what are the consensus statements? So one is the American Society of Anesthesiologists guidelines, which was released around 4 to 5 years back. And the other one is the Caring for Australians Renal Impairment Guideline, which was released in 2026 January. They say that based on this, another trial called as the Best Fluids trial, where they compared balanced crystalloid solutions versus saline. This trial was predominantly the DDRT population. The summarized recommendations are that crystalloids are definitely preferred over colloids. There is always a risk, as Dr. Avinash pointed out, of colloids causing the complications of volume overload, also drug reactions, and the understanding that in the post-operative period, there is a loss of glycocalyx, which could have an effect on the vessel wall and which could cause problems due to colloid infusion. So crystalloids are definitely recommended. The fill-up strategy is no longer recommended, so large volume resuscitation is not recommended. Pure CVP-based resuscitation is not recommended. Now, the more dynamic usage of CVP plus IVC plus stroke volume variation in addition to urine output and overlap of all these factors are recommended when you decide the postoperative fluid intake. Use of balanced solutions have now we have realized that it offsets the risk of acidosis-related transcellular shift in normal saline. But these studies have showed more benefit only in disease donor renal transplant more than the live-related renal transplant. In live-related renal transplant, so far, there is no guideline recommended best fluid of choice. So either the plasmalite or the normal saline can be used. Second is the pain control, and I'm sure the anesthesia team have done a clear explanation on that, so I would not dwell too much. But the choice that is recommended now is to go for a transverse abdominis plain block. This is for the incision site pain. For the postoperative period, paracetamol on an SOS basis with a minor dose of tramadol as and when required. Fentanyl is used for patient-controlled analgesia and pregabalin carbapenem SOS basis. NSAIDs are, as a nephrologist, always not recommended. The other thing which is recently also very often used is the dexmedetomidine, which is a central alpha-2 agonist. This is a sympatholytic with some role of a sedation. This is used as an opioid-sparing agent, and in comparison to fentanyl, this preserves the respiratory dive. The only issue is because it knocks out the sympathetic part, the risk of bradycardia and hypotension. So our patient, the pain part of it and the polyuria part of it settled, so he was discharged. Moving to our second patient. So this was a 36-year-old gentleman, native kidney disease of IgA nephropathy. He was on dialysis for 5 years, after which he underwent a disease donor renal transplant. For him, the post-operative day output was 2 liters per day, but on POD5, the creatinine was 3 milligram per deciliter. So this categorizes under slow graft function. We look back at why this could have happened, and this is due to, as Dr. Manas pointed out, intraoperative difficulties in anastomosis and the importance of the ischemia time. So whenever you have a disease donor renal transplant or you have a difficulty in the vascular anastomosis in the form of a double renal artery, you could end up with a prolonged ischemia time. To quickly reiterate what Dr. Manas had said. So there are 3 sets of times that you should be aware of. So first is the warm ischemia time, which is from arrest of circulation in the donor to packing of the kidney in the bag, which is the start of the cold storage. The cold ischemia period is from the entire period when it is packed in a bag and kept at a -4 degrees Celsius. This is considered the ideal temperature because it helps to soften the basal metabolic rate of the kidney and helps in preventing accumulation of the toxic metabolites. The second warm ischemia is when it is taken out of the ice box and then the anastomosis happens. This is the rewarm ischemia time. This is very minimal in a live-related renal transplant because there is no period of cold storage. There is just the initial warm ischemia, very minimal cold perfusion, and back to the rewarm. Whereas in a disease donor renal transplant, this cold ischemia is very prolonged. In our patient, so why we had a slow graft function was because of the recipient back table and the implantation time, which was slightly on the higher side. It is important to note that both the donor back table as well as the recipient back table ideally counts under warm ischemia because although you are perfusing, the temperature is not at -4 degrees. So what is our problem when the ischemia builds up? There is this entity called as the ischemia reperfusion injury, wherein there is a lot of ischemia. This develops hypoxia, and at the cellular level, this causes low ATP generation, anaerobic glycolysis, increased ROS production, and at the cellular level, altered calcium efflux. And once the clamp is released and the blood is reperfused, these inflammatory cells and the reactive oxygen species act on the damaged cells and activate your complement system. So this will cause a worsening of the inflammation and a higher oxidative stress, resulting in ischemia reperfusion injury. And this IRI is considered to be the major issue with causing delayed graft function. And for such cases with difficult anastomosis, our important investigation of choice is the allograft Doppler. I will not go into the intricate details, But what is very useful to understand is that if you look at the Doppler and you look at a uniformly perfused kidney, it is a good sign. Anytime that you look at a Doppler and you see a particular pole, and as Dr. Manas said, if the lower pole especially is not perfused, you could be in for a ureteric necrosis. So this is something that at the bedside should be easily assessed if the kidney is uniformly perfused. So for our patient, luckily there was uniform perfusion. So the creatinine dropped down from 3 to 1.8 back to 0.9 by POD 8 and he was discharged. Moving on to our third patient. So for her, she was a live rated transplant. Spouse was the donor. She had immediate graft function. The creatinine dropped to 1.8 by day 3. But on day 5, the creatinine again jumped to 3 milligram per deciliter. Her BP was okay. We did a Doppler and the Doppler was normal. Only issue was she started complaining of minimal tremors. So we evaluated and looked at the trend of creatinine and we saw that after POD 3, there was a slight jump in your serum creatinine. So why does this happen? A quick recap again of what was spoken regarding immunosuppression. So there are two categories. One is your induction immunosuppression, where your aim is to knock out the existing immunity. That you do by either ATG, besliximab or alemtuzumab with some steroids. And on follow-up, you give your maintenance immunosuppression consisting of tacrolimus, MMF, and steroids. So tacrolimus is predominantly the agent which is the calcineurin inhibitor, which blocks your T cells. MMF is the anti-proliferative agent, and steroids are used for generalized immunosuppression. The alternative agents are everolimus and belatacept, which are used only for specific indications. A common issue with tacrolimus. So if we look back at this patient's history and we realize that on post-operative day 3, the tacrolimus dose was increased from 2 mg BD to 3 mg BD. We sent the tacrolimus levels and we found that it was 14.2 nanograms per ml. So C0 or tacrolimus level is a test that is done in the blood to identify the lowest level of tacrolimus in the patient. For example, the patient is advised to take tacrolimus at 8 AM and 8 PM in the morning and night. We do a sample at around 7:55 in the morning, meaning to say we identify the lowest level of tacrolimus in the blood, which is why we call it as C0. So this C0 ideally is recommended to be around 7 to 9 in the immediate post-operative period and around 3 to 5 or around 4 to 6 in the long-term transplant patients. So for our patient, it was 14.2 nanograms per ml, and this high levels of TAC directly involve the graft and cause graft toxicity. Interesting things to note about tacrolimus is that it undergoes CYP3A4 metabolism, meaning to say that it has a lot of drug interactions from drugs. So if there is an addition of a fluconazole, if there is addition of any protease inhibitors, all these can end up to cause increased levels of tacrolimus. So any patient who is on tacrolimus, make sure that you have audited a strict drug history. The other thing to note is that now there is a test to identify the metabolizer status of a patient. So if somebody is a rapid metabolizer, they express CYP3A4 differently. So they will require a larger dose of tacrolimus to maintain the immunosuppression. In contrast, if there is somebody who is a slow metabolizer, they will require a slightly lesser dose to maintain normal immunosuppression. So identifying the metabolizer status is also a test that is readily available these days. The third thing is whenever there is diarrhea. So whenever there is diarrhea, this is another risk of causing increased tacrolimus toxicity, because this causes a decrease in the P-glycoprotein expression in the intestine, and this prevents absorption of your tacrolimus. So because of this, they will again increase your tacrolimus levels. So our patient, we then reduced the tacrolimus dose to 2.5 milligram BD, and we noticed that the creatinine started to stabilize to 2.1, 1.7, and 1.4. So moving on to our final patient. So she was a 45-year-old lady, again live rated renal transplant, father as donor, immediate graft function, discharged on POD7, discharge creatinine was 0.9, stable graft function for 1 year. 1 year post-transplant, she comes for a review and we identify that her creatinine has jumped up to 3 milligrams per deciliter. So as protocol, we do our renal artery Doppler, it is normal. We do a tacrolimus levels and it is very low. So although these help to get an idea of what could go wrong in the kidney, always an ideal option is to go ahead with your renal biopsy. So we went ahead with the renal biopsy for this patient, and this ended up to be an acute cell-mediated rejection with an antibody-mediated rejection. So there are 4 types that are commonly seen. One is the hyperacute rejection, which is seen on table when the kidney becomes purple, when there is major ABO mismatch. This thankfully does not happen now after the CDC cross-match. We then have the acute cell-mediated rejection and the antibody-mediated rejection, and finally the chronic allograft rejection. So these are our options. For our patient, we had combined both. So she underwent anti-rejection therapy. Anti-rejection therapy for acute cellular rejection, we go ahead with steroids plus or minus ATG. Whereas for antibody-mediated rejection, we go ahead with plasmapheresis, IVAG, and the treatment response is slightly poorer in compared to an acute cellular rejection. Our patient, she had a partial recovery. Creatinine dropped only around 1.9 milligram per deciliter. So this is a common scenario that we see. As long as the patient is in our surveillance and is in our follow-up, they tend to take the drugs on time. But within a period of 6 months to 1 year, when the graft stabilizes, there is a kind of lethargy which sets in for the patient. They tend to miss their doses, and this immediately triggers a rejection episode, which is why we always reiterate to the patient that every drug or every dose should never be skipped. And this is very important for long-term graft function. So to just highlight other causes of graft dysfunction, one is your surgical complications in the form of renal artery, vein thrombosis, any wound site infections or collections, lymphocele, and rarely there could be even urinary leaks. The others are the other side. We talk about rejection. What happens when there is too much of immunosuppression? This can end up with opportunistic infections in the form of BK virus nephropathy, CMV infections, or fungal infections. And rarely, from a nephrology perspective, recurrence of native kidney disease is also seen. One interesting thing is that the kidney does not possess any lymphoid organs. So the possibility of a graft versus host disease is very less likely. However, there is a rare entity called as passenger lymphocyte syndrome, which is the kidney's version of a GVHD. Rarely, when the kidney is transplanted, there are some lymphoid organs which are present in the kidney. So when there is minor ABO or RH mismatches, this could trigger a transient hemolysis causing a DCT positive anemia with thrombocytopenia. This is very rare, but this is the kidney transplant's version of a graft versus host disease. And this is a transient phenomenon which is self-resolving. So we saw 4 patients, all with a creatinine of a 3 milligram per deciliter. One was just the routine pain and polyuria. The other was somebody with difficulty in anastomosis. The other was somebody with drug toxicity, and the final one was somebody with rejection. Each was a challenge for each individual. The first was a challenge for the anesthetist to manage the pain and the polyuria part. The second was a challenge for the urologist. The third was a nephrologist. And the fourth was the patient's compliance. So there would be so many scenarios in the post-transplant period where we keep pointing fingers at each other. But it is important to understand that the graft experiences the sum of all our decisions, and it's important for all of us to keep the graft afloat. So transplant success is about, as Dr. Manas said, lies not in individual brilliance, but in the harmony of a coordinated expertise, and the working with a team that works together, like how it happens at CURI, is what is very important for a good long-term graft. So the take home, when you have a disease donor renal transplant, graft preservation is very important. Pain control and fluid optimization is key. Doing an allograft Doppler and looking at your tacrolimus levels are helpful. Always have a stringent watch for infections. Long-term graft outcomes, drug compliance is your key, and the donor well-being is our collective ethical responsibility. And always remember that post-transplant journey, it's about a marathon and it's not a sprint.
Make a mistake, it can cause a very serious effect on the recipient. So it depends on the coordinated work of everybody. And to highlight a few points on everybody's talk, first with regard to Siva's talk on pre-op evaluation, my experience on all these days, if the patient is having some native output, urine output, despite being on ESRD and on dialysis, I'll be very happy because I can give him fluids liberally on the table and he will excrete it without accumulating that. And if a patient gives history of missing one dialysis and going in for fluid overload and pulmonary edema features, I'll be very scared because I have to be very, very strict in giving him fluid prior to the clamp release. And we do not know how the kidney is going to behave after the clamp release. So that is one scare. Second thing, many of them are hypertensives. And they will be, I have seen patients taking 5 drugs to control the hypertension, and still the hypertension is 200 over 120 or 220 over 140. And the highest BP with which I have anesthetized a patient is 250 over 140. And it maintained throughout despite propofol induction and inhalation induction and fentanyl, everything, it was remaining the same. And the kidney was working beautifully. And patient recovered without any ill effects of that because he has been used to having that high BP all these days. So if the patient's blood pressure is on the higher side, I am more happy because as they mentioned, it is the grafted kidney is a pressure dependent kidney and it has got doesn't have a neural control. So I'll be happy to have a little higher side BP rather than, and if you observe constantly these patients, even though they have a high BP, once the external iliac vein clamp is applied, the BP will start dropping because the venous return comes down. And then once the clamp release has happened, because part of the cardiac output is going to the new kidney, it will take some time for the pressure to pick up. It will drop and it will take some time. And that is the time, many of the time, nephrologists and the urologists will be saying, sir, kidney is a little soft. Can you push up the BP? It will automatically come up, but their anxiety is it has to be all the time very tight and all the time well perfused. But in my experience, what I have seen is it picks up even though there is a drop, it will automatically come up. And the spurt of urine immediately after a clamp release is a good sign of good anastomosis and a good perfusion. So if urine starts coming soon after the clamp release at the ureteric tip, you need not worry, you can rush fluids and you can save the kidney. And so the pre-op assessment, you have to make a good assessment of the donor because the donor life is very, very important and precious. You can't afford to make any mistakes. And when I started the program, or was doing the program rather, we never used to accept the donor with any complication. Even hypertension was a taboo. But now we have relaxed the conditions We have increased the age of the donor even up to 65. We are taking the donors. We are taking donors with stage 2 hypertension. We are taking donors with mild diabetes. Provided they don't have any cardiac issue, all the people are accepted as donors. So we have to be more careful when you do the donor nephrectomy in a live donor program. Similarly, in the recipient, you give importance to the native urine output, his blood pressure, and his effort tolerance, and his ability to withstand the dialysis. If he has got no problem in acute drop in blood pressure after starting dialysis, resuscitated with 1 or 2 liters of saline, if this history is there, this is a very tricky candidate. You have to be very careful. So this is about the pre-op assessment. With regard to Ajay's talk, the matching is very, very important. You can't afford to make a mistake. So, of course, nowadays we are doing incompatible donor transplant also with plasmapheresis and other things. But there is always a risk of rejection on the table if you do such things. But with advanced technology in immunology, we are able to get good donors and the rejection problem is coming down. And the pre-op loading dose of immunosuppression drugs is also very, very important. So unless they give the correct dose, that may have an effect on the intraoperative period. And with regard to intraoperative management talked by Avinash, you have to make sure that you don't err on the excessive fluid administration before clamp release. You keep it to the minimum as possible, maintain the blood pressure, don't allow any hypotension to happen before clamp release or at the time of clamp release. And during clamp release, I have had 2 cases of hyperkalemic cardiac arrest. But luckily, we were able to revive those patients. So be careful. Do not leave the patient during the clamp release time. Observe the patient quite correctly in the ECG to look for any arrhythmias and treat it immediately if there is a hypertension. And even if you don't send the blood for hyperkalemia, if there is any brady or asystole, boldly you can give calcium gluconate to revive the patient. That will definitely work because it is mainly due to hyperkalemia and not due to any other cause. And with regard to surgical problem, we have had cases of even 2 branches or 3 arteries supplying, and many a time surgeons anastomose them together to make a barrel like artery and then make it a single anastomosis. But several times, as they said, you may have to do 2-vessel anastomosis. So once you know that, you have to be prepared for a longer duration of anastomosis and ischemia. So that kidney may take a little more time to work. So you have to be careful in fluid management again. With regard to the pain management, what Guhan said about tab block, I find that tab block gives more of a superficial analgesia and not a visceral analgesia. So instead of that, long ago, we started using wound infiltration before closure, both to the subcutaneous tissue as well as on the muscle, which has been proved to be very good. And patient has a good 12 hours analgesia with a simple 0.25% bupivacaine infiltration. And that makes need for lesser use of opioids, and recovery is much more faster. And as I was telling Satish, in my long career, I needed only, I had put only 3 patients on ventilator post-operatively for their inability to breathe adequately and oxygenate themselves. So otherwise, we can extubate them on the table, provided you are careful with the analgesic part of it. Even giving paracetamol, even though we consider it as a safe agent, it is better to restrict it because it is part, even though it is not strictly called as NSAIDs, it is better to restrict it as much as possible. And I have used tramadol at the end of the procedure, which gives a much better pain relief, not in the usual dose of 50 or 100 milligrams, but 25 to 40 milligrams is much effective in these patients. When they come out, they are very happy. And post-op, Guhan did a wonderful job by describing how the creatinine can go up again and how the fluid has to be correctly given. And again, as I was telling, I had seen a case where the first day urine output was 32 liters when we were doing transplant in Stanley Hospital. And we ran out of the stock of IV fluids. So we have to borrow from other hospitals to supplement because the hourly urine output itself was 1.5 to 2 liters. And then gradually the total output was 32 liters on the first day, which was I think should have been a Guinness record in these cases. So all of you did a wonderful job. And I think for the freshers or people who are not exposed to transplant anesthesia, this would have been a very nice program to enlighten them, increase their knowledge. Thank you very much. And any questions now? People can take up that question.
So we have a question regarding blood management in transplantation. The question is like,
I think they have answered that as far as possible before the clamp release or before the transplant program is over, even if the recipient is very, very anemic. I have seen patients because the earlier days, as I said, because of my long experience, we have seen people living with hemoglobin of 3 grams and 4 grams before erythropoietin was available. And those patients were happily climbing stairs, doing their routine work. So assessing the effort tolerance of the recipient is a very, very important point because body naturally gets so much acclimatized by 2-3 dpg increase in the heart rate and increasing the cardiac output and shift of the OTC curve, everything adapts themselves to normal life without any strain. And so chronic anemia, you need not worry. By giving a blood transfusion just to push up the hemoglobin to 8 or 9, you are making the patient become more sensitive and the chance of rejection are more. So that is the reason why we would like to avoid. And with the availability of erythropoietin and iron supplements, which are increasing the hemoglobin, I don't think there is need for any transfusion in the recipient.
one final question. Suitability of using regional anesthesia as a standalone technique for conducting donor nephrectomy or transplantation itself?
Donor nephrectomy, I think regional will be a punishment for the patient to be on the lateral aspect, and however much you try to sedate them and all, it is not natural. So from human consideration, I won't accept that as a technique of choice. If at all you put an LMA and then make the patient sleep, that will be a safe technique, but not awake fully with mild sedation alone in the lateral position. Of course, in the government setup, we have done nephrectomies where surgeons used to finish it in 45 minutes to 1 hour in lateral position, cajoling the patient, say that it will be over, don't worry about the position, because your arm starts aching because you are going to rest your body weight on one side. Upper limb pain is more. Even though your operative site is completely numb, it doesn't make it useful. And for the recipient, I have done 20 cases under epidural, and only one case in my career I have done it under subarachnoid block itself as a recipient program. And there the problem is epidural at least you can accept because the hypotension will not be very severe. Whereas a single shot spinal, the hypotension is much more drastic and to maintain the blood pressure, especially during clamp release, is difficult. That is why now most of the centers have stopped doing anything under epidural or spinal. Central neuraxial blockade is not the preferred unless you have some problem in the lung where you cannot ventilate. The indication for my case where I did it under spinal was cystic fibrosis of the lung. Patient hardly had any, but he was young. He was only 40, 38 or 40. So we could not refuse transplant also. And he did well after the surgery.
Thank you very much, sir. I think with that, we'll conclude the session. I take this opportunity to thank all members in the audience for the presence, the continued enthusiasm in participating in the series of CMEs on perioperative medicine. As rightly pointed out throughout the series, throughout this particular session, it is not an event of a single department. Many departments have to come into place. They have to do a lot of activities. And there is no set of activities that can be said as exclusive to a particular department. And if all such activities are effectively put in place, at the end of the day, the patient gets to have an organ and he goes on to live a healthy, happy life. Yeah. So that's the take-home point. I thank all the speakers for their immense inputs, and I thank the administration and management of CURI Hospital for the endorsement of this CMEs on perioperative medicine. Thank you, sir. Any words? Thank you all.